So you're keeping well, Posa?
Yes, I am keeping very well today. It is very gloomy outside. It's raining. But
Ataku is gloomy.
Oh, it's gloomy. Yeah, we need the rain. We can't complain.
Yeah, you thank God for it.
Okay. I think we'll start and then when what's his name? When Austin is able to unmute and wake up and come, we'll just continue. Okay. So good morning, the people in the States. That's for sure. It's Dr. Agenta and I. And good evening, the people in East Africa, mostly Kenya. My usual partner is out of commission. Sir is a bit unwell. For those who believe in a higher faith, please pray for him. He'll be back, I think, the next meeting. But yeah, for now, let's keep him in prayer. So today we are tackling we are continuing the discussion on addictions. Last week we did process or behavior addictions. And this week we are doing substance use, or what we commonly know as drug addiction. And since we have a new person in town, Dr. Agenta, do you want to start us off with what your definition of addiction is? And then we will continue from there.
Okay. So morning, everyone. I'm Dr. Agenta. So I just want to start by saying that whatever views that are expressed are mine. So it's not really where I work or anything, but the definition of addiction, it's not mine, it's ASAM. So there's the Society of Addiction Medicine, the American Society of Addiction Medicine. And over the years, they've worked on trying to get a definition that is kind of all encompassing. And so pretty much we know it to be chronic. We know it to be complex. There is a whole lot that has gone into the definition to try to destigmatize, because one of the biggest things right now is around stigmatization. So there are a lot of terms that we're changing. And as we talk, I'll try to tell you some of the words that, we're phasing out. But basically it's treated, it's chronic, it's medical, it's a medical disease. It's not just a disease of willpower. And it involves complex interactions among brain circuits, has to do with genetics, the environment. And so people with addiction could use substances or engage in behavior. So just like you guys are talking about last week, you're talking about behaviors. Right now, we're going to be talking about substances. And the overarching thing is that these things cause harm. They lead to harm. So that's the definition right now that internationally, that's what has been put out there.
Okay. Albert, do you want to add on to that, or do you want to Kenyanize the description? Austin is having a few challenges because he's in upcountry. Let's call it upcountry. He's in Bunyore. So right now he's not able to join. So we'll make do with what we have. So Albert, okay. Do you want to add on to that, or do you want to Kenyanize it?
I think maybe just to simplify what Dr. has just said, addiction is a disease of the brain, okay? And it is one where it's a lifelong disease, and it is something that the addict will have to deal with throughout their life cycle. But I also feel there's also need for other members, a bit family and the community, to really understand that it is a disease and that it is something that somebody will live for the rest of their life. And if I might add, sometimes addiction can end well, sometimes it cannot end well, especially when you're dealing with substance abuse. So, for example, people who are into hard drugs, like be it cocaine or heroin, sometimes depending on the level of addiction, if it is severe, unfortunately, they tend to have an overdose. So for me, I just like to reiterate that and emphasize those few key points. Thank you.
Okay, and Dr. Agenta, do we know what predisposes people to be addicted to substances, and are there substances that are more addictive than the others?
So if you look back at the definition, like it tells you like it could be genetic, it could be environment. So some people may tell you, yeah, it runs in my family, I have a family. So a lot of times when we start to talk to a person or a patient, you know, we try to break down the history. What was your first use? What did you use first? Do you have a history of this in your family? And so sometimes you see, oh yes, it runs in families. Sometimes you find that now we're talking about what we call gateway drugs. Gateway drugs basically are those first substances that someone uses and then gradually progress to something else. So sometimes we've added tobacco to that actually. So nicotine, marijuana, a lot of people, we're talking about the opioid crisis now. So opioids are basically, we could say, pain medications. You know, they're natural and synthetic. So talking about morphine and anything that is similar to that. So some people may start as, oh, I had a surgery or I had an accident, I got some pain medications, and gradually the body builds tolerance. So you may start with a small dose and then that can escalate. And so even the pain medications that are prescribed are no longer able to control the pain, or you cannot get the euphoria that you were getting at first. So you need something higher and higher. That's how people get into heroin. And now fentanyl is the big one that's really causing a lot of deaths here just because of the potency. Alcohol use, you may find people say, oh, I started as a teenager, or I started as a little kid. So anything that really, when the brain is still developing, so in younger kids, and so the brain never fully develops. And so that's the big risk for a lot of people who start young. And so those are, I would say, the predispositions.
Okay. And Albert, I know the situation in Kenya is a bit different. If you could talk about what predisposes us, and also the big gateway drugs we have, and if you could also break down the what we mean by gateway drug. Austin, if you can send salams and tell me you can talk, let me know. Albert, go ahead.
Hi, Posa, can you hear me?
Oh yes, we can hear you. Okay, yes, I can. Let Albert go, then you can go.
Sorry, I was interrupted a bit. What was the question again, Posa?
The question, the same one I asked Dr. Agenta about what predisposes some people to drug addiction or substance use, and she also mentioned the gateway drugs and the kind of addictions we are mainly seeing in the in Northern America. So if you could talk about what predisposes us, the gateway drugs in Kenya, and and what substances we are also seeing being abused back home.
Okay. I think for me, what I would add on to what she said, I think even the aspect of just experimentation, one, could be a cause. I'll also put in the aspect of peer pressure when you're with your peers, especially among young people. I'll also throw in the aspect of mass media for another. I would also throw in the aspect of, to some extent, culture, where you find that in certain times, you find that maybe alcohol is accepted for certain functions, and depending on somebody's genetic makeup, okay, when they get used to alcohol, that somehow stimulates the brain, and they may end up getting addicted to the substance. Now in Kenya, there's an increase in abusing of definitely marijuana, for one. Definitely, we even have got PrEP, the abuse of PrEP. That is post-exposure prophylaxis. There's an abuse of Panadol. There's an abuse of, it's called what? Piriton, because of its antihistamine properties. And there's also abuse of codeine, the cough syrup, you know. So just as Dr. has mentioned, it starts slowly, and then over time your body builds tolerance, and now that's how you become addicted to the substance. But having said that, I would also say sometimes the community setup can also perpetuate this. I speak like this because, having worked in one of the informal settlements in Nairobi, one of my biggest learnings is that sometimes alcohol and substance abuse, especially substance abuse, happens in some form of system. Here we call it the cartel, whereby things are moved from one person to the other, but it's under the purview of some people in authority. Of course, the people who are not well behaved in authority. So because of that, the peddlers and those with ill intent are able to conduct their business, and that's how consequently they thrive. They do that in various disguises. They do it in the disguise of doing it in shops, for one, or sometimes they even have, I dare say, sometimes some parents in the informal settlements, even as they send their children to go and sell things like sweets, things like even peanuts, it's also an avenue in which they peddle some of these drugs. Yeah, thank you.
Austin, are you able, or let me clarify. Panadol is acetaminophen, Dr. Genta, and Piriton is chlorpheniramine. Codeine is codeine.
I'm familiar with that.
Okay.
The only one I would have thought about, though, would be PrEP. I'm not sure why they would be abusing PrEP.
Yeah, because you see, they take it, when, how do I say, because you're going to engage in sexual activity. Mm-hmm. So the fact that, in case it's easily accessible, so people just go and get it on the counter. So then young people get used to it. So you keep on taking it over and over, to keep yourself safe.
Is it giving them a high, or they're just taking it because they want to have sex?
I think initially, I think it's the bit for sex, but then over time, again, tolerance. It makes you feel a particular way. And then also, I forgot, even family planning medication is also being abused.
Oh, I think I saw it. Was it in Malawi where they are also abusing, the material that's in diapers? There's that substance, the gel. They're getting diapers and removing some fluid from it and injecting it. People do things. Gosh, is Austin? Are you able to talk now?
I don't know if you can hear me.
Yes, we can hear you. You can talk. We've done the definition, and we were talking about a bit about the predisposing factors, and yes. And the drugs in our the common substances that are being used in our in our setup. And I would really, really want us to delve a bit on the gateway drugs, because our countrymate Austin Wajakoya wants us to legalize the stuff. So just talk a bit about that.
Okay. But before that, maybe there's the question that someone asks. Why do some people become addicted to drugs while others do not?
Yes.
So many at times for us who are in the addiction field, we usually talk about vulnerability, that we seem to have different levels of vulnerability to addiction. And mainly, whenever we talk about vulnerability, we are looking at the interaction between the individual's biology. So as my colleagues have mentioned, the genetic factors, we are looking at environmental factors, and we're also looking at age. So those three interactions then determine the type of vulnerability that an individual has. So for example, you may find in certain families from one generation to another, they have a history of alcoholism, for instance, whereas in another family, you may not find that kind of history. Then you may find there are people who are living in neighborhoods where access to those drugs or substances is very predominant compared to other neighborhoods. For example, someone who stays on Chai Road in Pangani has access to heroin compared to someone who stays at Amboseli Drive in Lavington, you know, because of that environment. Then age. Many at times we don't expect people who are above 55 to start initiating drug use, whereas maybe you'll find people who are in the young adulthood and in teenagehood, you're finding that there are those who are now initiating certain types of drug use. So that's really is the question, that why do some people become addicted to drugs while others do not? Mainly is because of the element of vulnerability. Now, one of the things that has happened recently is that we are learning that addiction is like other diseases. Why do we say that? Because number one, addiction is preventable. The same way you can prevent hypertension, the same way you can prevent dysentery, addiction is preventable. Then the other criteria that we use to maybe clarify about the disease concept is that addiction is treatable. There is treatment for addiction, which is available. As my colleague has talked about the American Society for Addiction Medicine, for example, they give us placement criteria for patients, and in each placement criteria, we get to know which type of treatment an individual is suited for them. The other thing also is that addiction changes an individual's biology. Someone who is addicted to cocaine, for instance, their brain is significantly different from someone who is not addicted to cocaine. And you can be able to do different types of imaging techniques to see what is different in terms of the individual's biology. Then the other criteria that we also look at is that if it is untreated, it can last a lifetime. Now, this is a polite way of saying, if it is untreated, it can kill you. So many times whenever we talk about certain diseases, if those diseases are untreated, it can last a lifetime, meaning that some diseases actually end up killing you if there is no treatment. So if you look at what happens with some of the institutions of addiction treatment, one of the things that we do at the time of admission is that we do a medical history. Depending on the sophistication of the facility, some of the facilities actually take imaging techniques, brain imaging techniques, to show the clients that your brain has significantly changed, whether it's about the tissues, whether it's about the specific organ, so that the individual knows that as I'm in this treatment, in treatment for a brain disease, in as much as it manifests itself in behavior. I don't know if that answers you, Posa, now.
Yeah, yes, it does. So my question is, with the whole neuroplasticity of the brain, is this reversible? Once I've taken cocaine for N years, is my brain stuck in that cocaine rut, or due to neuroplasticity, it can change back to teenage innocent me, and anyone can take a stab at this?
I think sometimes it varies with the intensity of the drugs that someone used, whether they were only using one drug or many drugs. But for many of our clients, there are those who, for example, who are alcoholic. You'll find their brains had atrophy, so meaning their brains had shrunk in mass. And for some of them, it has never gone back to normal, so to speak. You'll find there are people who still behave like they were intoxicated because of these changes that took place. However, also over the years, what we have learned is that with good nutrition, with good self-care, individuals are now rejuvenating themselves. And for some of our clients, you'll find within the first 2 weeks, 3 weeks, 3 months, 6 months, you meet them, they look very different because of the nutrition they are getting, and their bodies are really improving. So yes, for some of the clients, yes, it happens, they're able to go back to almost the innocent brain, so to speak. However, as my colleague had said, if someone had already started using drugs before the age of 25, their brains had not yet fully developed. So of course, the drugs interfered with their full brain development. And that again also has an impact on it rejuvenating to the original situation. Maybe I'll hand over to my colleague to add more.
Okay, and Dr. Agenta, I still want us to talk about the gateway drugs, and because I want us to discuss about vaping and marijuana, and why the push to legalize the stuff is not very helpful, and the role nicotine plays and in all these. And also, if you could mention the substances, especially the immigrants of African origin are abusing in our setup. That's in Minnesota because we are many. And then the same question would be to now my Kenyan colleagues.
Okay, so let me start with, so brain changes. The brain does change. That's why we're talking about chemical changes in the brain. Can it go back? That's yet to be known, but I'll tell you this from talking to patients. The first high, they never get back. There's something called chasing the dragon. The way you felt the first time you used the drug, you will constantly chase that. And so even that's why we talk about, and I say this, when we talk about chronic conditions, I say it's like high blood pressure, diabetes. Maybe you'll have to take meds for the rest of your life, or maybe you'll have to manage it for the rest of your life. You may not be cured. There may be a constant reminder. If you see someone smoking a cigarette, or you watch TV and you see an advert, or you see a bottle of alcohol, you may get triggers, but it's teaching people how to work through it. It's whether it's 12 steps or whatever, or meds that they're on to try to replace that imbalance. It's trying to, work through the condition. You have the condition now. How do we get through it? How do we help you not to go back to that? Because that's the thing. That's why people constantly may go back to the substance, but it's all about trial. Keep trying to quit, keep trying to quit. Even if you quit, especially, I wouldn't say even especially, but let's use cigarettes as an example. It's one of the hardest things to quit. And I keep telling people, just try, try again. Because that's the disappointing thing. It's like, oh, I quit. Why can't I quit forever? There's some people who can quit cold turkey forever. It's like, I never touch a cigarette again. But there are people who are like, I've tried like 50 million times to quit. And it's like, just keep trying, So I think there are definitely brain changes that may not get repaired or may not go back to the way it was before, but it's trying to find new circuits to bypass the addiction. Then you asked about the gateway drugs. So basically, nicotine, alcohol, marijuana, prescription drugs, anything that really was kind of your first introduction. A lot of people won't start with like the big drugs. A lot of people won't start with like the big drug. They may start small, just like you're saying, peer pressure. It's like, oh, my friends wanted me to try this substance and I tried it. And then it's like, oh, maybe I should go for something higher. I'm not familiar with research on the Black population in Minnesota with regards to what substances, but I'll tell you that in the US, opioids are the crisis right now. Last year, we had about 100,000 deaths that were attributed to opioids. And that's really because of fentanyls. If you talk to paramedics or hospitals, or the big thing right now is fentanyl, because I was saying how potent it is, where when people get on fentanyl, the part of the problem is because of how potent and because of what it's laced with, or if they're using fentanyl to lace something else and they didn't realize fentanyl was in it. So they're more likely to overdose on that. In terms of marijuana, it's highly politicized. I wouldn't even go, but I'll tell you, there's a lot of money in marijuana. And one of the other things is there is still no consensus in terms of, unlike opioids or alcohol, they can say, okay, when you take this, the body is addicted to it. But with marijuana, they're saying that sometimes it actually does not cause really an addiction, which I don't particularly agree with. But there's a lot of money in marijuana. So it's just like alcohol used to be prohibited, where you had to bootleg or you had to do illegal things to sell alcohol. And then when they find that there's a lot of money in alcohol, it's like, oh, okay, why don't we make this legal? And then after that, why don't we put an age restriction? So I think we're seeing that with marijuana right now, where we finally legalize it, but we are having problems with that. Like in the emergency room, when Colorado was the first to legalize here, they started to see things in the emergency room that they had not seen before. Some, because of now, it's not just something you have to smoke, it's in like candy, it's in food, it's in gummy bears. So sometimes children are getting, they may see like, oh, a gummy bear, so they're seeing ER visits with more children who ingested these substances. And just things like that. There's some people who have what we call cyclical vomiting syndrome, where they smoke marijuana, they throw up. They smoke marijuana, they throw up, but for some reason they're unable to stop. So there are a lot of side effects. But at the same time, some people say, I can quit whenever I want to. But it has to do basically with money. Yeah.
Albert, do you want to have a go at what drugs are you seeing? I know you mentioned some, but what are the big kahunas in terms of drug substance use in our setup back home?
Okay, I think for sure we've got nicotine through tobacco, cigarettes, definitely marijuana there. Prescription drugs is another. We also have increasingly family planning medications that are also being abused. Now, what I'd like to just add on to what Dr. has said before I delve into the gateway drugs is that just as she mentioned, addiction changes your brain. So what then happens by extension, various parts of your brain are affected. The hippocampus, the amygdala, the precortical and the prefrontal cortex that deals with issues around decision making, sleep disturbance, and etc. And that is why over time, based on the level of usage, the person has got short-term memory, they can't make decisions clearly, they cannot think clearly, they're very poor in sleeping, etc. Now back to our abuse substances in Kenya. So I'd mentioned we've got nicotine to tobacco, we've got weed, you also got Mira. If I forget, Mira is a big one. You've got also prescription medications and also family planning. Now, if I may just touch on, let me take the marijuana because it's something I've really engaged with, especially in my work as a community counselor. It's the issue of affordability, okay? Because one, you find that it goes anywhere between 10 shillings to 50 shillings, okay? And now you can imagine the informal setup, 10 shillings is easily affordable. That's one. But also number two, there's also need to understand the context and how the business is thriving. I say this because you realize there's always that issue of supply and demand even within this space. Because remember we've got the drug peddlers, number one, who go and pick these drugs. And they know their customers. Okay, so if I may just give a scenario, you are in an informal settlement and you want to, assuming I'm a peddler, so I know I get my consignments from person X, and because person X knows I've got access, I can move around and I know where to go, I'm given, and then I go and I distribute. Now, incidentally, sometimes that happens in full glare of authority. So you find the authority even end up being part of it. Of course, those ones who are deviant. And one thing I also witnessed some time back, I witnessed some law enforcement officers, even, I remember it was around midday, around lunch hour, actually moving around picking money from the peddlers. Okay, so that will give you a context for you to know that yes, this drug is there, but it's also being sustained by the existing authority. Now, what is also happening? So by default, then what's happening, because it's been sustained, it's then now moving into various places. So for one, it's getting into schools through students, and also as Dr. has just mentioned, now even we've got candy, we've got cakes, you know, that are being sold, and sometimes it's sold to even unknowing people, you know, so you end up eating and ingesting rather without even knowing that you're ingesting weed. All right, and what then happens? Then slowly by slowly, you'd want to always get that high that you have. But something else I feel that is also a challenge when it comes to that is the aspect of also treatment. I say this because number one, we do not have enough centers to treat some of these problems. And sometimes even the follow-up is not as great as it should be. Why do I say so? Once again, I look at the informal settlements because that's where the vast population of Nairobians live, and even in the rural areas, but I'll speak about the informal settlements as that has been my area of engagement. So number one, even access to those facilities could be a challenge, one, because of distance, and number two, because of even lacking that transport, and number three, because even lack of that knowledge. But also something else is even lack of knowledge that even that substance is a problem to you. Because having engaged the community members and those who indulge in it, sometimes they don't see it as a problem, because they will tell you, whenever I take it, I concentrate better, I'm more alert, I do my work better. So they don't even see it as a problem. In fact, they feel it's a catalyst, it enhances their work. So then it then requires a lot of unlearning, relearning, and a lot of sensitization on the same. Yeah, I feel there's need to perhaps take community counseling really down there. And even I know we've got NMS clinics that are situated in various spots within the 17 sub-counties of Nairobi, but sometimes they don't even know that they exist. Okay. Yes, I think I'll leave it at that juncture.
Stephen, if you have a quick question, you can ask, and then we'll go to Austin. And I want us to shift the conversation to the chicken and egg story. And this is in terms of mental health illnesses and substance abuse. What precedes the others? Are they cousins? Are they correlated? And all that. Stephen, do you have a quick question or a comment? Your hand is up. Stephen Morethi? Okay, Austin, go ahead.
Thank you for the question. Sometimes what has happened is that when we do counseling for persons with addiction problems, as I had mentioned in the last week, one of the exercises that I like doing with my clients is for them to write their life story, and also for their family members to do a collateral letter where they are able to express themselves in relation to their loved one's addiction. Now, many times also these two documents help me as a practitioner to know, are we dealing with an addiction problem, or are we also dealing with another mental illness? Now, for me, for the client, it doesn't matter. For the family members, it doesn't matter, because at the end of the day, they will say, we notice there's a difference in behavior of our loved one. So that is what the first step starts. What differences do you notice in your loved one? Now, the practitioner's role at times now becomes to interpret, what is this different behavior? What does it mean? And many a times then that interpretation leads to a designation and saying that this is a diagnosis of this type of issue. Having said that, I know there are studies that have been carried out locally amongst patients in the mental hospital and also amongst clients in rehabilitation centers to see if there is comorbidity of mental illness and substance use. So you'll find, for example, amongst those who are found to have a diagnosis of alcoholism, a number of them also had a diagnosis of major depression. Then also amongst those who had cannabis use, there are those who are found also to have a psychotic disorder. And of course, then the question was, when you ask the client, the patient, why they were using the substance, for some of them, they reported that they used the substance to feel normal, for them to be able to function. So in a sense, it's like there are those who, as we talked about vulnerability, there are those who are using substances to self-medicate, so to speak. Self-medicate in relation to how they are feeling or how the drug makes them to feel. So the important thing mainly for practitioners is that as we do the history taking, as we do the screening and assessment, is to be able to assess both for the substance use and also to assess for both for the mental illness, and then to be able to make appropriate referral or appropriate treatment plan for the clients. Because at the end of the day, many of our clients or their family members may not be interested to know which caused the other, but at the end of the day, they want to feel better. So we try to integrate it in such a way that now my access to treatment has to be wholesome. Am I getting treatment biologically, psychosocially, spiritually? Am I getting the appropriate referrals and the appropriate interventions? So that's how I would tackle that question on a mental illness versus substance use.
And also, Austin, on your side, in terms of drugs, are you concurring with Albert, or are you seeing anything different?
I think for me, two things influence also the choice of drugs. Number one is the aspect of personality, and then the other aspect is the aspect of exposure in terms of economic background. Because, for example, I have interacted with clients whose first drug was dexamphetamine, for example, in Kenya. And you look at the economic profile of this family, it is a family that is well off. Or you find also someone who's using cocaine or who is using heroin because of the environment that they were brought up in. So normally that's how I would look at it. There are times I'm also cautious about using the phrase gateway drugs, because what happens is that it's like we're minimizing the habit forming or the addictive properties of those specific drugs. The reality is, yes, there are some people who start off using nicotine and then they graduate to other drugs, but it doesn't mean that nicotine is not addictive to this person. Because what happens is that now, when they get into treatment, they start telling their counselors, heroin was my problem, alcohol was not my problem. So don't talk to me about abstinence to alcohol. Another client used to tell me, oh, cocaine was my problem, but tobacco was not my problem. So don't talk to me about abstinence from tobacco. Now, the unfortunate thing is that some of our treatment facilities, in as much as they're helping our patients to deal with alcoholism and other forms of drug addiction, there are those that still allow their clients to smoke tobacco within the premise. And what has happened is that we then talk about the concept of cross addiction, meaning that I stop being addicted to one drug and I'm now moving. It's like my psychological energy moves towards addiction to another drug. So of course we had a movement within the addiction professionals where we tried to lobby the owners and managers, the clinical directors of the different facilities to adapt an, how would you say, abstinence-oriented treatment modality. And here we are saying within the premise of the treatment facility, we are abstaining from all, as much as possible, all addictive substances. Over to you.
Okay, and cumulatively, by the way, tobacco has done a lot of damage. As someone who hung out with Dr. Agenta's colleagues in the pulmonary world, the bread and butter of chest physicians in this country is primarily due to tobacco. It massacres you if head to toe. And I'm with Austin there. We need to think about the habit forming and the destructive the distraction that tobacco goes, and we need to stop belittling it as a drug. I want us to move to how to treat substance use disorders, because like if we are calling it a chronic illness, there must be way to manage or treat. I know Dr. Ese is tending to baby now. So let's start with Albert. And if you can, Stephen, to your question, let's just say it's multiple things. It could be genetic, and as we've spoken, it could be the environment, it could be mental illness that's leading that whole family to be alcoholics. Albert, let's start with the treatment. Dr. Agenta, when you're back, just let me know.
Yeah, I'm here.
Oh, you're here. Okay, let's
Yeah.
start. Albert, ladies first. Let's start with the Dr. Agenta.
Okay.
Oh, sorry. What was, you said treatment?
Yeah, let's manage. Yeah, let's manage the substance abuse.
Okay.
Substance use, yes. Substance.
So it depends on the substance. Now, so before, in the past, we used to talk about mostly behavioral therapy for a lot of addiction. And it was almost a taboo to say that you wanted to try to use medications to treat addiction. So that's why we used to talk about Alcoholics Anonymous, 12-step programs, cognitive behavioral therapy. But now that we're recognizing it more as a medical disease, we have started to talk more about using other medications or treatment. So for opioids, we have what we call medication-assisted treatment or therapies. The big ones are methadone and Suboxone. I don't know if in Africa, like I haven't really heard in Nigeria us talking about methadone or Suboxone. So you guys will let me know about Kenya too. But here we're talking, basically, we know that the substances change the brain's chemistry. So what we're trying to do is replace some of that chemistry or the abnormal chemistry with these other medications in such a way that the people are able to go about their normal activities, like they're able to hold a job, they're able to take care of their families, where they're not constantly trying to get maybe a needle or get, an illegal substance. So methadone is what we call so many of the drugs work as either like an antagonist. So methadone will try to push the drug off of the receptors. Not to go too much into the chemistry, but basically they're replacements. I just call them replacement therapies. But they also have their own issues. So like methadone is very restricted. You have to go in every day to get the medication from a facility and a doctor that has been credentialed in that. Suboxone is pretty much the same, but you're able to go, now more doctors are able to get credentialed to prescribe Suboxone. You don't need to go in to get a prescription every day at the same time. And then just like we were talking about mental health disorders, yes, a lot of people who use substances are more, people with mental health conditions are more likely to use substances. So the other thing is trying to treat their mental health condition. So if it's like anxiety, there are people who I know who say, if you give me something for anxiety, I probably won't drink. But the problem with that is most of the treatments for anxiety is like the benzodiazepines, like Valium, lorazepam, diazepam, lorazepam, and all of those are also habit forming. So if you can treat the mental health disorder, alcohol, we also have several medications too. Some like antabuse or disulfiram, what that tries to do is when you drink alcohol and you're taking this medication, it makes you sick. So the thought process is that, okay, so I will stop drinking because every time I drink alcohol, then it makes me sick. But what you find is that most patients actually stop taking the medication because they want to drink alcohol. So we have other things like naltrexone, which you could take as a tablet every day, or we're also finding these other meds used to be solely for opioids, but we're finding that it helps with alcohol. So you may get like a monthly injection most of them are to help with craving, that craving of, I really need to go drink alcohol, you know. So if that craving is gone, then maybe you will not go look for the substance. Yeah. So those are the big ones. Marijuana, I don't believe has a treatment as of yet. Nicotine, okay, so talking about, just like you said, yeah, tobacco is a big one. In the US, it's very accepted. If you read about the history of most of these substances, at some point, they were regarded as harmless. With nicotine, you hear about people who came back from, I think, World War I or II, and they were actually given tobacco as gifts. Cigarettes were given as gifts. With opioids, now that we're suing Big Pharma, talking about, oh, at the time they were telling doctors, just prescribe, it's harmless, prescribe, prescribe, prescribe. You know, so people got hooked on this. So like nicotine, there's a generation who tell me, you know, I started smoking when I was 12. I started smoking when I was 13. But now you see that the younger generation, the advertisements, the nicotine companies are trying to advertise to the younger generation to make it look cool, you know, and that's when we talk about vaping too, where it's like, oh, if you smoke, you know, you're cool, you're popular, you know, so teenagers want that. So nicotine, we have nicotine replacement therapies. So like the gum, the inhalers, the patch, or you have other medications like Chantix, which is Wellbutrin, which is can be used for depression, that can be used to treat. But a lot of patients will also tell me, I've tried all of those, they never worked. Or a lot of people also say, why will I replace one substance with another? So that's the big thing, is trying to do a lot of education on, well, if you are going to a shady part of town to go stick a needle that may be HIV infected, that is not good. Let us replace it with this other tablet. You know, so there's a lot of education into that about, you can go on with your own life. Why don't we treat it like high blood pressure or diabetes, where you have to take a medication every day to help you with this? Yeah.
Okay. Albert, go ahead. And just for knowledge sake, one vape has the equivalent of 20 cigarettes. When you look at the CT scans of these teenagers who are smoking, they look like they've smoked for 40 years. So when you're seeing someone vaping out there, and if anyone is selling vape products in Kenya, something needs to be done. Albert, go ahead. Same question. Yeah.
Dr. Austin, I'm just curious. Is that similar to shisha? Here?
No. There's shisha. Shisha is like a hook you smoke. It's a different product, but it's a cousin to it. It's the same mechanism. So a vape, looks like, by the way, it could look like a pen, like this, as in it's flat, like a flash drive, but this long. And then they just, if you look at all these Hollywood celebrities, like Doja Cat was vaping just before she got her BBA trophy. Don't ask me how I know. I know. Yeah. So it's in a cartridge. But shisha and is like a hookah. It's in that kibuyu, for lack of a better word. And then people. But it's the same thing. We are destroying our lungs. Yes.
Okay.
Yeah.
Okay. If I may just add on to what Dr. has just said, away from that, I also believe in there's the aspect also of having a group counseling, which is very, very key, with people suffering from the same kind of substance abuse, be it alcohol, be it cocaine, be it mirror. And I say that because everybody has got their personal experiences that they'd like to share. And the beautiful thing about such sessions, you're now able to really identify what I call serious issues that then warrant the one-on-one sessions that then translate into the individual counseling sessions. So for me, there's the group counseling sessions, then preceded now by, which then now leads to the individual counseling sessions. Well, at that, I think there's, as part of treatment, there's need to have what I call mental health talks, where we basically equip them with various life skills, how to manage your stress levels, how to handle your emotions, how to be more creative, how to be a problem solver, equipping them with skills, of course, by giving them case scenarios on what they can do in order to solve to handle their various challenges. Another thing is also having a good referral pathway. And referral pathway here is letting them know where they can get help. In Kenya, we've got quite a number of toll-free lines. For instance, we've got, I believe it's NACADA, I think it's 1192 or 1196. So the toll-free lines, very, very key. We've got various organizations with hotlines that are working. So it's very important for them to know that. Another thing, there's also need, and it is even happening, where we have the community health workers who are now actually equipped with the skills. And there's a document that's owned by the WHO called the Problem Management Plus. That basically enables community members to be able to, identify various stressful situations and come up with various coping mechanisms. And in a way, this then makes these people what we call quote unquote lay counselors. Because remember, it will not be possible to have the traditional counselors be there on site, okay? Something else that is also very key, there's also need to link them with the various clinics. And in my case, I'm talking about with the various sub-county clinics that are run across the county of Nairobi, including all the major hospitals that address these addictions, whether it's Mathare Hospital or I think even Kenyatta Hospital, if I'm not wrong, so that they know where they can get this help. But I think for me, fundamentally, is also this need in our end for continuous sensitization on some of these drugs, because like as I mentioned earlier on, especially when you're dealing with members of the community, they may not find drugs such as, and I must be specific here, whether it is, let me say, the cat or Mira in our case, and bang, to be bad because they say for them it's a catalyst. It enables them to do their work better. So for example, there's a time I was having a chat with one of the guards, and he told me, a guard and a driver who drives long distance, that for him, as he's driving a long distance, he has his soda, he has his groundnut, and he has his cat. Because with the cat now he's able to be alert and does not fall asleep. So for this person, you can see it's not a problem. So there's need for sensitization, and then by extension, unlearning and relearning. Yes, thank you.
Austin, you're up.
Thank you. My colleagues have mentioned basically what I would have talked about. However, I think what I can add is in regard to the principles of effective treatment. I'd mentioned this in the last session. There are a number of principles that we have that guide us in terms of treatment. One of those principles is that no single treatment is appropriate for all. So that means that each individual who comes into a counseling room or a practitioner's room, normally the practitioner has to do an assessment to be able to determine the type of treatment plan. So no single treatment is appropriate for all. The other issue is about the availability of treatment. Ideally, we say that treatments need to be readily available. However, if you look at the Kenyan context, the treatments that we have available are within the private sector. A lot of treatment is within the private sector. Little is in the public sector. So you find that the private sector seems to have developed more in terms of making the availability of treatment. Then my colleagues have also mentioned about meeting the multiple needs of clients. So as we provide treatment, we also strive to meet the different needs of clients. That is why you'll hear practitioners will talk about biopsychosocial stroke spiritual assessments or treatment planning, just to meet the different needs of the client. Now, one of the things that has happened over time is that we have learned that remaining in treatment for an adequate period of time is critical for treatment effectiveness. So you will hear of treatment programs that talk about 90 days or 180 days where someone is in treatment, because we realize that the longer someone stays in treatment, then it also helps in terms of effectiveness. Of course, we talk about counseling and other behavior therapies as part of the treatment. My colleagues have mentioned group counseling, individual counseling, so that usually is a critical component. The other component is about the medications, as doctor has already mentioned, the different medications. They are also an important element of the treatment. We have also talked about coexisting disorders being treated. So if someone has a mental illness or if someone has other medical problems, as they come for addiction treatment, we need to make sure that also those disorders or diseases are being dealt with. Then something that is very common now in Kenya is detoxification programs. You'll find some people will go for detox and think that detox is treatment. So normally we try to clarify to them that doing a detox program is not necessarily the complete treatment, but it is a component of treatment. Then the other controversial principle that we practice, we normally say that treatment does not need to be voluntary for it to be effective. As I'd mentioned, we've had instances where family members, loved ones, we've had workmates, employers who have forced people to get into treatment. And so when someone has been forced into treatment, it is up to us, the practitioners, to use our skills for them to be able to see, okay, why am I in treatment and why have my loved ones referred me for treatment? So treatment does not need to be voluntary for it to be effective. We've had people who have been mandated by the court system to go for treatment. Then, as I'd mentioned about diseases, when people come for addiction treatment, we also do screening for other diseases like HIV, hepatitis B and C, tuberculosis, and also other infectious diseases, because also we realize that for some people when they are in addiction, their self-care is wanting. So you find maybe they also exposed themselves to other diseases. And maybe the final principle also that we normally promote is about recovery. Now, we say that recovery is a long-term process. So meaning that the individual cannot wake up one morning and say, I have recovered from addiction. Because what is the understanding of recovery? Normally, we talk about recovery in two ways. Number one, abstaining from the substance as one component of recovery. And number two, implementing positive changes in your life. So you cannot say, I have fully abstained, and you cannot say, I have fully implemented positive changes, because this is really a continuous process. So meaning we say recovery is equals to abstinence plus positive change. So those are some of the principles that we use in terms of accessing treatment. In Kenya, as I'd mentioned, a lot of our facilities privately owned, either by limited liability companies, owned by charitable trusts, owned by community-based organizations. And so you'll find in the NACADA website, you'll be able to see the different facilities according to the counties. For instance, Nairobi has 22 facilities. We have Kiambu County has 15 facilities. Kajiado County has 11 facilities that are offering addiction treatment. So you'll find, depending on which county the individual is or your loved one is, you can be able to make appropriate referrals for them. Over to you.
And yes, Dr. Agenta, we have methadone in clinics in Kenya, yeah, people go there every day. I just want to.
Can I mention something about the methadone treatment?
Okay, go ahead.
Yeah, so yes, we have them in Kenya, and there are those who look at it as a harm reduction technique, meaning it is a means to an end. And there are those who are looking at it as an end in itself. What do I mean? So from a HIV prevention point of view, the methadone clinic is really working well for the injecting drug users, because now they no longer need to inject themselves and share needles. Now, from an addiction point of view, it is a means to an end, meaning that when they come for the methadone assisted therapy, the counselors now have to start talking to them about eventually being weaned off methadone and also getting into an abstinence-oriented type of treatment. So a lot of discussions are ongoing between Ministry of Health, between NACADA and all the other practitioners to see how best to effectively use those facilities. And again, you know, our methadone clinics are still donor funded. One of the biggest donor is the USAID that is helping in terms of the methadone clinic. But yes, they've really made a big improvement for many of our clients in terms of HIV prevention, in terms of improving their general health, and also getting them into long-term recovery for addiction.
So my controversial question today, the same way we've made alcohol safe, we've moved, okay, in Kenya, we've not really, we still make Busa and Changa, but we've moved away from moonshine, clean, you know, the crude way of making alcohol, and made alcohol safe and tobacco safe. And now that addiction is here to stay, I'm just wondering, how is it possible for my friends know I say all these big drug dealers in Kenya need to have like a cocaine bar that is safe with clean cocaine and all that. Is it too controversial a thing, or is that something addiction specialists are looking at? If we can't beat the addiction, why not make it safe by having a safe supply of these substances? And anyone can take a stab at this.
So I just want to say alcohol is not safe.
I know it's not safe, but
it's legal.
We've made it bougie and a bit clean.
Well, it depends on who you're talking to, right? If you're saying, oh yeah, I have a glass of wine here and there, but when someone is telling you I drink 1/5 of alcohol, what if like a whole bottle of vodka daily, you know, that's about what, 40% alcohol? It's not really safe. And people still have moonshine everywhere. We have moonshine everywhere. It's not gone. But even vodka or bourbon or whatever, you know, the hard alcohol, it's still really concentrated. You're just thinking that some people just take a shot glass, but some people drink a whole bottle or more a day and still end up where they shouldn't end up.
Okay, because you see in the US, the reason why people are dying now, I know heroin has been pushed out of the market because of fentanyl. And that's why it's like I've been trained in, this is
Narcan,
Narcan. Yeah, I have been trained and I have a Narcan, whatever, in case someone gets OD somewhere, I can administer it. And as in we've okayed this, I'm just wondering, for us not to have this, why can't we have like a clean supply of opioids in the street? This is just me being controversial.
There are some places like New York has some places, it's very controversial. They're what we call needle exchange programs, and is it clean houses? There's something they're called, where people can go, they give them clean needles, they help them inject. It's very controversial. It's a way to help them get the substances safely, you know, to prevent like HIV and hepatitis and all of those other illnesses. But we're yet to see, I think it's still early. They're probably doing studies now to see how effective, or, you know, that is.
Okay. From the Kenyan side, will my mother beat me up when she hears me saying that?
I think for me, Posa, indeed it's controversial. And I know there's one presidential candidate, right, currently, who said he wants to legalize marijuana. But the truth of the matter is, I don't think the Kenyan society is prepared yet. I think for such things, they need to be prepared psychologically to embrace such things. But having said that, maybe, I don't know, you can never tell, maybe in the near future we could get there. Because I say that because honestly speaking, the rate at which people are smoking weed so openly nowadays, at our Kichangi, they even smoke it passing by a police without even, they don't even bat an eyelid. So for me, perhaps sometime in future it could be possible, but I know it will be met with a lot of resistance, especially from the religious and other members of the society, including legal practitioners, because then again, there's an argument, if you do that, then you're also encouraging people to indulge. But on the flip side, indulging is still happening, and it's happening in an unsafe manner, and I dare say in the darkness, quote unquote, because it's also very private for most, again, depending on the context that you are in. So for me, my own opinion, perhaps in the near future, but right now, psychologically, I don't think the Kenyan society is prepared for something like that.
Austin, you are in the land of weed right now. What's your take on it? On my controversial question.
Thank you so much. I mean, Bunyore at the moment as I speak to you, and Bunyore is well known for cannabis planting and use. I think the big question is, can one use an addictive substance safely? I think that's one of the questions that we may need to ask ourselves. Can one use an addictive substance safely? And the reason why I was saying that alcohol is standardized and legalized is because if you go to the Kenya Bureau of Standards, they have standards for different types of alcoholic beverages, so to speak. And the belief is that if the manufacturer follows those standards, then the users are safe to use those beverages, so to speak. So now the question would be, is there a level of safety for use of cocaine or use of heroin or use of any other substance? So that's the first aspect of that question. The second aspect of that question is, can someone use these addictive substances socially, occasionally? Again, it depends with your own answer. But at the end of the day, I think we need to remind ourselves that drugs change the brain. I think that's the key message, that drugs do change the brain. And normally when a person first tries drugs, you usually say, or you'll hear someone says, I decided to use the drugs voluntarily. Maybe it was through experimentation or through prescription. However, after repeated drug use, deciding to use drugs is no longer voluntary because, again, drugs change the brain. So I think for me, that will be the key message. Even as we try to respond to this controversial question, the key message is drugs change the brain. Now, because of that, then I'm of the opinion we cannot use any other adjective to accept social use of certain drugs.
Okay. I just want us to, okay, we need to start winding down, which takes forever, right? But let's tackle the core addictions, the behavioral and substance. And we forgot to discuss, you know, there's been an upshoot, that's English, right? An upshoot of the retirees in Kenya getting into gambling, and someone also mentioned the increase of drug use. Can we talk about the core addictions and how to bulletproof everyone from drug and behavioral addictions? Anyone willing to start? Ini Onyuroan. Anyone willing to take a stab? I don't have a preference of who to start. Anyone?
Let me think.
Okay. Austin, do you want to start? Albert and Afkiria.
Okay, let me start. So, as we had mentioned last week, that amongst the people who were addicted to processes, to behavioral addictions, there's also comorbidity or the risk of them getting into substance use disorders. So there are studies that have been carried out to see someone who, for example, has a pathological gambling, those who got a diagnosis of pathological gambling. There's a study that found between 35% and 63% of them were also using substances. Then in the same study, they looked at people who had addiction to internet addiction. 38% also had a substance use disorder. In the same study, they also looked at compulsive buying. 21% also had a predisposition or rather had an experience of substance use disorder. So what does that tell us? I think the message is there are those who might think about some individuals could be having an addictive personality. That is one possibility of looking at it. Then the other way of looking at it is that there are those of us who will be having a substance use disorder plus a mental illness. And so you'll find if someone has this disorder, there's also the risk of them getting the mental illness. Now, substance use disorders and mental illnesses, whenever we do prevention science, a lot of times we find they have the same risk factors. So the risk factors for mental illness are also more or less the risk factors for substance use disorders, depending on how you look at it. Whether you look at it in terms of genetic risk factors or environmental risk factors or even age as a risk factor, you'll find they have this similar risk factors. Then the other thing also we have learned is that treatment for one illness should also focus on treatment of the other. So for example, if someone comes for a mental illness treatment, the nurse, the counselor, the psychiatrist will also want to find out, do you have a substance use disorder? Are we able to screen you for that substance use disorder so that we can be able to treat both at the same time? Then in terms of treatment, a lot of times also we have learned, we integrate behavioral treatments with medication. So for example, if I'm giving you treatment for depression, Maybe I'm giving you medicine, antidepressants. I'm also combining the antidepressants with the cognitive behavior therapy, because we realize that as we treat both the mental illness and the addiction, then we're able to give you effective treatment. So for me, that's how I would look at it from my own experience, that there are those clients who will present with 2 or more conditions at the same time. And it is up to us, maybe as the counselor, for me to be able to pick what are some of these conditions that my client is presenting with, and am I making appropriate referrals to the other multidisciplinary team members in terms of the treatment.
Okay.
Yeah.
Albert, do you want to go?
Yeah, though I'll touch on the behavioral bit for retirees when it comes to gambling and etc. I think for me, when you reach that level of retirement, you're looking for something to do. And I think for me, the fact that perhaps, that one was not or is not in a position to, they did not plan out the retirement, for one, could be a reason. Because what is gambling all about? Gambling is that hope that you're going to you're going to make it big, isn't it? You're going to get the big back, okay? And the question is, why would you want to do that? It's because somewhere at the back of your mind, you know you need that money, so you're lacking. So I think the aspect of perhaps maybe either lack of proper planning or either poor financial management could be one. Another thing could be the pressure. There's just general pressure to gamble. Okay, from again the external factors, be it friends, be it family, be it the mass media, there's that. Thirdly, general idling. Idling could be another reason, because it's also a way of keeping yourself busy. Okay, and the more you get into it, the more you get addicted to it. And I know at home you've got this game, you call it Ajua, maybe you know it, Posa. And you find that people wake up, men, and I understand even women nowadays, you by 8 a.m. you're playing it, you come back, you're playing it, you go, you break for your lunch, you're still playing it, you come back in the evening and you're still playing it. So then that tells you that it's also a way of also dealing with idling. Something else I think also is also a symptom of, I think, an element of, I dare say, societies. Okay, how do I put it? There's perhaps there's generally just that lack of awareness of really the impact of what such addictions are. In fact, people don't think it's an addiction. Many people don't think it's an addiction. So that's sensitization, yes. There's need for it. Because you find that every other club has got a machine somewhere. You know, you've got the betting farms all over the place, okay? Another thing, the affordability. It's so affordable. You just need 20 bob, 10 bob. So that can also lead to some of those addictions, such as behavioral ones, specifically issues around gambling. Thank you.
Dr. Agenta, are you still with us?
Yeah.
Okay.
Yeah, I think I agree with what everybody's saying. And it's based, like, if you take gambling and alcohol, they're, you know, which one led to which? The gambling can lead to the alcohol use, the alcohol use can lead to gambling. And I think you also see that because some of the places, like even casinos, they're set up, they may give you free drinks. You know, there's the disinhibition. It's like, okay, let's give them a lot of alcohol to drink, and then you think that you're on top of the world and you spend more money gambling, you know. So it's just like you're saying, there's a predisposition So someone who's predisposed to alcohol use may be predisposed to gambling. It may be the same thing that they're trying to treat a mental health disorder. So I think they all can coexist.
Okay, and I think also capitalism is a big deal. When you watch I think it's called The Social Dilemma on Netflix, it talks about how these things are very addictive. Even when you look at like a can of Pringles, the crisp chips in this country, the way it's shaped and all that, someone sat down and did the science. Even Doritos, someone sat down and did the science to just make those substances very addictive. Even the social media, someone sat down and did the science to make it very addictive, so that even CoComelon, so that it can feed someone else's pocket.
Yeah.
I think we have.
And they do research, these companies have a department whose job is to find out how can people get more hooked on this? How can people continue to buy this? How can people continue to, use this? They spend billions of dollars every year to keep people using these things. Yeah.
Okay. I think we've covered in my head all that aspects. I just want us to do the closing remarks. If you have a question for any of the other panelists, no one ever has questions for me. And yeah, and just the last remarks and hope. And we will start with you, Austin.
Thank you. I think what I can say is that we are living in an age where advances in science have really changed our views on addiction, so to speak. From the scientific point of view, we know how drugs change the brain. And these advances have also helped us in terms of treatment planning, in terms of the types of treatment to make available, and how to help our loved ones to deal with their addiction problems. So a lot of times we just don't talk about as social problems. We are dealing with brain diseases, and science has really helped us to really understand when you say it is a brain disease, what exactly do we mean, or what parts of the brain have been affected, and how do we help the individual who has been affected in those parts. So yes, our understanding of science has really changed our view of addiction. That's what I would say for now.
Let's go to you, Albert, and if someone can address Atara Solutions questions, if sex and porn addiction, do people heal or is it like drugs? And we touched a bit on it last week, so Grace Nzula, go look at our video last week, but Albert will address that. Albert, go ahead.
Okay, let me address, then I can give my final remarks. Indeed, sex and porn is like any other addiction, perhaps could even be even more severe, because remember here you're dealing about pleasure, you're dealing about, you're handling, the issue of the dopamine, that hormone that brings pleasure. And the unfortunate thing about sex and porn is that once not addressed appropriately, can really bring problems to you as an individual for one, and even between you and your partner. I say that for the following reasons. Let me get a bit controversial here. Some of those things, let's remember, when people are acting in porn, those are actors. Okay? Some of those things, you can't practice them physically. And it can bring certain problems to you and your spouse. Having said that, I'm also aware that sometimes, as a way of spicing up one's, bedroom, I know when people are having challenges, when they go see the specialist, sometimes they're taken to a room okay? And they watch it, but that now serves a specific reason. But in this case, I'm looking at, let's say, young people or the youth, you know, and this can really affect you. So for example, you will always be thinking about it, which means now you won't be able to study, you won't be able to work. So instead of working, you're going to, let's say you're going to just be focusing on Pornhub. So that will end up affecting your work. So you need to be as productive as you should be, okay? You'd end up, secondly, even spending or wasting your money, you know, either you'll be spending your money getting hookers, you'll be spending your money getting escorts, you'll be spending your money downloading all sorts of videos on the internet just to satisfy that urge of yours. So yes, indeed, it's a very, very powerful form of addiction, and I believe if anyone is going through it, they really need to get the help that they so much deserve. So as I wind up, for me, I'd like to end by saying, remember, at the end of the day, we're all human beings. None of us can say you're completely immune. I say if you've not experienced directly or indirectly, you're vulnerable. The thing is, know it is there for one, but also know there's help. There's help, and you can always find your way to handle it. You can always find your way to get through it. But I also must add, remember, and reiterate that addiction is a chronic disease. It's a disease. And remember, many addicts are functional. And not just functional. Some there are many addicts who are addicts, but even physically they look okay. You know, you can't even tell that they're addicts, you know, perhaps because they have got the capacity, they've got the financial muscle, they are either eating well, but that does not that does not remove the addiction part of it. So in as much as you're an addict, yes, you may just let yourself be, not take care of yourself. That's one way. But also we've got the functional addicts who are able to take the drugs, are able now to function effectively. But I'll also emphasize a purpose to know various referral points. You know, it could be hospitals, it could be clinics, and even toll-free lines that could be of help both to you or to other persons that you may know that are undergoing various forms of addictions. I'd also encourage us to purpose to know to study more and know about the various forms of addictions, especially in our respective countries for one, and in our respective locations, so you can know exactly what specific intervention you can give. Thank you.
Thank you so much. Dr. Agenta?
Yeah, I would say, just like we're saying, it's a disease, and these are people and people's lives. So I would say be kind. And if there's nothing else we take away, I think just the terminology of it's not a drunkard, it's a person with alcohol use disorder, it's a person with addiction, not an addict, you know, things like that. Just trying to remove the stigma so that people will seek treatment. Yeah.
Yes, we need to destigmatize, and we need to use people fast language. We have to change our minds, and it's a paradigm shift. I'd like to take this opportunity to thank, okay, we'll start with Mgeni. Dr. Agenta, thank you so much. I will also thank Dr. Diebold for hooking us up. Thank you very much. Albert Erokamano Ainya. Austin Mbuomuno, thank you very much. I know we are going to meet again, because of course I'm going to misuse you until the day I get money to pay all of you. From next, yeah, I have said I'm going to miss, because this is for people who can't afford therapists. At least we are providing a forum for them to understand, and for their families to understand these diseases. Next month, I have been avoiding tackling family trauma, and we are going to start. So from next month, we are going to get bits and pieces there. So I will set the same way you get this flyer, you get it. Thank you very much, Asanteni Sana. Unless you have a burning question, we have come to the end. Kenyans must eat. Americans must have brunch. Asanteni sana, and happy Memorial Day. I don't know if we say happy or and happy Madaraka Day, right? June 1st, ndio? Yes.
Yes.
Both countries are having a long weekend again. Okay. Yes, and Albert, contact is there. Austin, you can put yours. Dr. Agenta, yours. I know we cannot use you because we of the differences in countries and all those other things, but yes, thank you very much. Mkutano umeisha.
Thank you. All right, I'm going to jump off.
Okay,
Bye.
bye-bye.